All right. Hi there. My name is Jerome Bermudez. I'll be walking you through my presentation for project number 5, nursing educator simulation. I'll be considering the barriers, considerations, and best practices. And yeah, let's get started. So, uh, acting as the subject matter expert for simulation on a diabetes program that we talked about in project number 4, I have to discuss what the simulation standards of best practices are. And with regards to facilitation, first of all, who's the facilitator? The facilitator is actually the person that's responsible for the students. They're like the instructor, they're their evaluator, but they're also their like cheerleader and encourager. So their job is really quite twofold, to also to teach the patient, to teach the students, but also to get them to help them feel encouraged that they can succeed in it, because it's a very different kind of way to show your competency by actually being part of a clinical like scenario than being at the bedside at a hospital or filling out a like a multiple choice question test. It's a completely different thing. So facilitation. There really isn't a strict blueprint for how to do how to facilitate, but it is important to recognize that there are some things, there are some points that we have to hit. Effectively, though, there's still a lot of creativity and there's still a lot of individual style involved considered here. But when it comes to the points we have to hit, being effective, one is having the skills and the knowledge to be able to teach to adults. That's part of being an effective facilitator. The second thing is the approach itself. Do they have the appropriate, are they approaching this from an appropriate direction as far as the student? Are they approaching their students with the appropriate um, level of experience? Are they teaching for them to have knowing that what their level of experience and competency is? Because knowing those things ahead of time will help the facilitation process better. There needs to be a pre-briefing, and lastly, progression. That's just referring to how a group progresses through the scenario, trying to get to the learning objectives of the scenario. Means that the facilitator has to kind of hint and cue the um, the students so that they don't get stuck, or so they don't get led astray into somewhere where it was totally unintended. So yeah, effectiveness. Is their approach correct? Is their pre-briefing done? And are they progressing appropriately as expected through the scenario? The second thing is debriefing. Debriefing is about feedback. What the students and the peers, they get a lot of benefit out of knowing how they did. It's kind of unilateral, so the kind of the students are sort of taking it in from the facilitator, but reflection is sort of the student reflecting on what they've heard and trying to critically analyze how they did, and facilitators have to be a part of that as well. So yeah, confidentiality though is kind of summing up the end effect of what kind of the what the debriefing what those what debriefs kind of invite is sometimes some kind of unrest or uneasiness amongst the group, and so the it would be good for the facilitator to be prepared to provide assistance or to provide help or immediate support for students who are trying to get to grips with kind of how they look like on camera, how they kind of sound like when they talk to a patient. It might be the first time they've ever heard themselves talk the way that they do. And then evaluation of learning and performance. This is about, let me turn the page. Three things here. Being a formative evaluation means that you're focusing what we're saying in the evaluation to be about developing clinical competency and trying to monitor progress or encourage progress. Because the end goal is really to get the students uh, their simulation time to be for helping them feel like a real nurse in the end. Feeling like a professional nurse is the hardest thing to really um, believe in until you're actually out of school and you're doing it on your own. But there's a lot of dangerous things that we want nursing students to experience under in controlled circumstances, and that's what simulation is good for. So and then summative evaluation. These kinds of scenarios are good to do when you're evaluating the for all of the skills that you have taught the students. So at the end of the semester, this is a good way to evaluate them. Again, this is a good way to do high stakes evaluation. Um, Ultimately, if there are gaps in knowledge or gaps in skills, it'll probably come out during simulation. And that'll be very helpful and useful to us and to you as instructors. Um, okay, so here's the scenario. Since we were talking about diabetes last time, my students will have been med-surg students who just finished the first med-surg rotation, or maybe like it's their second class in a bachelor's program. So they're familiar with what diabetes is and some of the complications. However, they're still not at all at the level of ICU, and they haven't quite entertained the thought of it. So this is a 58-year-old male. His name is MQ with a history of hypertension. He was brought in by EMS. He was complaining of sudden abdominal pain. He was tachypnic, he was hyperventilating, he had a fruity smell to his breath. On imaging, his pancreas was normal. Blood work results supportive of DKA with blood sugars of 850 and then an ion gap of 18 and CO2 of 5. All of this is to say is like this is what an ICU patient would look like, but of course again they're not ICU nurses or ICU students yet. They're just med surg for now. So the patient was admitted to ICU and eventually downgraded to med surg, where the nurse is caring for him in this simulation scenario. And so what the twist in this scenario is that the nurse will come in, evaluate the patient, and find that the patient's actually doing pretty fair middling. They're not nothing particular comes out, and they're expected to check the patient's blood sugar and then get the insulin and give the insulin to the patient and then check to make sure the patient feels like they're going to eat. And then we start to hear words from the facilitator who is talking through the dummy. Hey, I don't think I'm going to eat, or I think I don't feel like eating, or I don't like that I'm eating because that's why I'm diabetic. You get the sense that the reason that this patient might not eat for you because they were recently diagnosed with diabetes. Again, we saw the hypertension history, but there was no diabetes history. So we don't know how the patient feels about having been diagnosed with diabetes. It could be a sense where they're becoming maladaptive and they're choosing not to eat anything. And that might be happening right there. So what happens is the patient decides not to eat. They've already sent enough cues to the nurse to know that maybe this might happen. And the nurse kind of gives the insulin as trained. And then the patient has a little bit of hypoglycemia and they start to have like these like non-specific signs of uh, hypoglycemia like shakiness and clamminess and sweatiness and a little confusion, very slight non-specific things that should tip off the nurse. Maybe the nurse does another evaluation. Maybe they're not sure what they're seeing, but the exciting thing is maybe to me that the nurse kind of pieces it together that they gave insulin and the patient's acting different, and maybe it's because they didn't eat, and maybe now is not the time to try to get to the bottom of why they're not eating, but the next thing they should probably do is check the blood sugar, find out if the blood sugar is too low, give them something to get their blood sugar back up, and then evaluate them and see the kind of what the reason for what was going on more from the 30,000 foot level. So if we haven't reached that point yet, then That's fine. Hopefully the facilitator can kind of help them, maybe throw in a phone call from the wife and say, oh, my husband was kind of talking about this and that. Maybe he doesn't want to eat. Maybe he does eating everything always make the blood sugar go up? No, 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 no. And maybe, hopefully the nurse kind of pieces it together, interviews the patient again, asks them what's going on, and maybe they can get like something out of them that helps them understand that maybe this patient is incredibly depressed and they're having maladaptive symptoms from dealing with their diagnosis, and that they should talk to a dietitian. I mean, most diabetics probably already talk to a dietitian in the hospital, but in this case, it's actually affecting their ability to keep a healthy blood sugar under treatment. So as far as our interdisciplinary piece goes, um, the use of knowledge it would be, well, okay, it'll be competency 6.3. Oh, my light went out. One moment. Okay, I apologize. I am back. So competency 6.3, use knowledge of nursing and other professions to address healthcare needs. Subcompetency 6.3b, leverage roles and abilities of team members to optimize care. What the patient and maybe the patient's doctor or maybe the patient's wife is hopefully cueing the nurse into saying is, maybe I should ask the dietitian to help to change the verbiage in our messaging so that the registered dietitian can kind of take into account the attitudes that the patient's having about their eating habits. So it would maybe help just to use our nursing knowledge to help the the registered dietitian tailor their care and make this work better, for our patient. So that's my interdisciplinary piece. And yeah, in the end, the patient will maybe get a consult from psych. Sure, maybe they'll just get a little scared into eating better. But in the end, I think this is a good critical thinking piece because it forces, it needs, it requires the nursing student to take a step back and say, like, how did this happen? When did I start to hear the clues? And is it really that? Because maybe maybe a nurse's presumptions about how patients become diabetic or how they deal with it will be formed in this scenario, and will help them grow professionally. So what are the potential barriers? If we were talking about starting this uh, program, I think the audio-visual limitation, according to Flowelling, is a real issue. Um, in a simulation, there's a one-way window, and in that one-way window, the evaluator can and the facilitator can see into the room, and there are cameras involved with microphones and things like that. It's perhaps the best surveilled room that's not in the hospital, but is meant to look like a hospital. It's certainly better than the hospital, but there are still limitations. There still isn't the chance that the evaluator can really look under here, look under there, or see how the nurse is actually checking the blood sugar, and seeing them load the strip into the machine and what have you, and how there's still things that you can't see, but it's better. It's still a limitation. So with regards to high stakes evaluation, that can still be a real problem. The second thing is standardization and evaluation consistency. I think it would be good to incorporate Flowelling's tool. I haven't said this yet, but the article itself was evaluating the validity of a tool that could be used to evaluate students who are going inside, who are doing a scenario. And standardizing that should help because there's still a lot of subjectivity that goes on in evaluating how well a student went through a scenario. Then there are the technical limitations and accessibility. These smart robots are very complicated. They are considered high fidelity, but maybe only if 100% of the components on that um, robot, that mannequin, that mannequin is working correctly. So I think even in my own experience, mannequins have little things wrong with them all the time. It kind of takes you out of the immersion. It's degraded. It's not the high, fidelity that you wanted. You're having to ask the facilitator, what is the pulse? Can I feel it? Is it thready? Is it strong? Is it bounding? Are the pupils moving? Is their mouth opening? There's a lot of things that could go right. A lot of things that do not work right, and accessibility is like the very most difficult part because any kind of machine will break, but to have the machine there in the first place is an accessibility problem, and then accessibility uh, to um, technology maintenance is still a challenge. However, I'll consider the nurses that needed this kind of training during COVID. That was every kind of student. No student was really considered yet safe to go back to the hospital, but to get simulation training was what the quality of their education was really riding on. And these are my sources. My name is Jerome. Thank you for listening. Until next time.